All right, everybody. Thank y'all for coming back. My name is Kurt Kennedy. I'm one of the pediatric ICU docs at Texas Children's Hospital. I would like to thank you all for having the fortitude to stick around to the end of this. I don't know about y'all. I have had my head filled up with just so many ideas and the speed that we have gone through things. I'm intellectually swimming right now, so I'm hoping that I can pull off this moderator job with any degree of competency, but give yourselves a hand for sticking it out. I'd also like to thank Anthony and Lauren and their scores of people that have helped them put this conference together. They've done a very good job. This is the most innovative conference I've ever been to, and I'm very excited to be here. I am honored to be on the stage with my panel. These guys are rock stars in their own rights, and I feel privileged to be up here on the stage with them. Hopefully I can get through this with giving them the recognition that they deserve for being up here. I'll go ahead and finish up my part and then just turn it over to you if that's okay. Okay. So what I want to open up with is, I know that a lot of the focus here has been on the young innovators in the crowd, and rather than talk about what I do specifically, which would probably put you to sleep, I want to talk a little bit about kind of the motivation and kind of the core problems that inspire me to do what I do. And I've kind of put it into 4 domains, and I'm not going to hold anybody else accountable to them, but for what it's worth, this is what they are. So the first problem is it has to do with automation of data. If we used our cars like we used our EMR, we would push them to the gas station, pump all the useful gasoline into them, push them back home, soften out the gas, put it on the bonfire and light it up and get started. And that's just not the way to use it. That's ridiculous. So we need to get the data to work for us and reserve humans for actually doing the human things that they do, that's interacting with patients and thinking. Next slide. The second problem is, we're exploding with data now. It's not just coming from all the new technology in the ICU, it's coming from home. It's coming from all these other places. And it's a big where's Waldo problem. If Waldo's out there, I'm tired of looking for Waldo. Waldo needs to find me. It's time to grow up. And frankly, he needs to be smart too. If he's got a beer for me, he needs to interrupt me and say, here's your beer. I would appreciate that. If it's my stool softener, wait until I'm off stage and then I'll check that out. And then Waldo needs to find me wherever I am. If I'm in my office and it's important, let me know. If I'm in front of another patient, let me know. Next slide. The third thing has to do with cognition. We've talked about what is reality. And as humans, we all have grown up with our own individual biases on life, and we see things in different perspectives. And there's power and information in all of those perspectives, and we need to learn how to utilize that. We are kind of constrained to the dimensions that we're constrained to. We think in 2D, sometimes 3D. It's very hard for us to think in 6 dimensions. Computers, that's just part of how they're built. They can do that. So let's leverage that ability from them. Next. And then finally, it kind of goes to this concept of who owns knowledge. And, I would make the argument that nobody owns knowledge. In the old school system, the doctor was supposed to know everything, and you go to the doctor and he tells you what's wrong, and that model is dead. Parents, in many cases, are much more knowledgeable about their kids than we are, and it's hubris that a lot of times will keep this from moving forward. We need to change our culture to where we share this knowledge as equal partners with them and bring everybody to the table. Let everybody put their piece of the puzzle in on this so that at the end of the day, we've got a very clear picture that everybody understands. Now, the trick to this is it's very easy for me to look on a patient and make a gestalt impression, and very often I'm going to be right. So whatever we do or whatever we build, it needs to be that easy. It can't be something that's onerous and complicated. So with that, I'm going to go ahead and turn it over to Marty Cohn.
Thanks. And again, I am impressed that so many of you stayed till the end. I usually get scheduled as the last session on the last day of programs, and speak to 6 people, so I'm a little nervous right now.
Oh, sorry, guys. Yeah, we just need to get her done. That last slide was actually my fun slide, but that's okay.
We can go back.
No, that's good. Go.
So first, I am not a pediatrician. I am not a critical care intensivist. My clinical practice was emergency medicine. There was a period of time that I treated children early on in the history of emergency medicine before pediatric emergency medicine started, but I'm not. I'm an engineer and a physician, health policy analyst. I've been a congressional health policy advisor, and a background in health management, finance, and operations research. So I look at data in a very broad way. This is now my 50th year working in healthcare. I started as a research biomedical engineer in the 60s. So one of the first things I look at is why are we starting to do what we do? Why are we looking at real world data, big data, artificial intelligence, and all these analytics? And a key part of it is that we've recognized that we need to make better decisions for individuals, personalized healthcare. Now, if you go to the people at the genomics displays out there, they're going to claim that they invented personalized healthcare. Okay? Not quite true. The very first article I ever read about personalized healthcare is July 4th, 1968, New England Journal of Medicine. I remember the date because that's when I started medical school. First article I read in the New England Journal. Talked about the need to know enough about your individual patient to make better decisions for that patient. The problem was back then we couldn't do it, had no ability to collect or use or understand the data to actually be personalized. So our gold standard for evidence back then was the randomized controlled study. And that's what you talked about on rounds. And the person who we most in awe of on rounds was the person who had the encyclopedic knowledge of the literature and could quote study after study to you. The problem was, well, again, getting back to personalized data, it's not just genomic data, it's all the clinical data that we need if we're going to be able to understand people really well. Because until genomics can tell us why identical twins have different outcomes, it's not complete. If we look at published data, we find lots of disturbing things. John Ioannidis from Stanford, as well as many other authors, have reviewed literature and found disturbing things like most results, even in the most respected journals, can't be reproduced. So our gold standard for data is kind of tarnished, not very encouraging. I gave a similar talk to a group of pharmaceutical CEOs and executives, and they claimed that, well, that may be true of healthcare in general, but not the pharmaceutical industry. So I did some research on the pharmaceutical industry, and it turns out they're even worse. And there was one study that showed in a typical report, published report from the pharmaceutical industry, they only include about 20% of the data because they don't want you to know the rest. So we have a problem with it being flawed, but even at its best, randomized controlled studies aren't very helpful in making a decision about an individual. There are population studies. They compare one group to another, and on average, Group A did better than Group B, or Group B did better than Group A, but it tells you nothing about the individuals in each of the groups. And undoubtedly, some people in the group that did better, on average, did worse, and some people in the group that on average did worse actually did better, and we don't know that. So it explains why early in my clinical experience, if you tried an intervention that was recommended from a randomized controlled study, 30% of the people didn't respond because it told us nothing about the individual. The other limitation is you can only do an RCT on something you thought of ahead of time. So if there's something really important out there that you didn't think about, you'll never find a study for it. And further, the area in which I work now in patients with multiple chronic diseases, you'll never find a randomized controlled study on a patient who has both CHF and COPD and diabetes. You'll find studies on individuals, but how do you optimize the care of a patient who has, say, coronary artery disease and asthma when you can't treat that patient by optimizing both diseases? Won't be in a randomized controlled study. You're only going to get that from real-world data. So what's different about real-world data? First of all, there's a lot of it. Okay. So a lot of it means a big challenge and great opportunities. Okay. Because if there's a lot of data out there, there's a lot we can possibly learn. Now, I think there's a fourth V, adding to one of the earlier speakers, there's a fourth V for big data, which is a challenging V, and its level of challenge is expressed by different people have different fourth Vs. Variously here, variability, veracity, and value. Variability because a lot of that data is uncertain or simply wrong. You have your ICU patient, and the ART line says the heart rate is 120. The EKG monitor says the heart rate is 60. Which is the correct one? A study at IBM, when I was there as chief medical scientist in 2012, concluded that 80% of the data we collect in healthcare is at least uncertain. So we deal with that variability. The other possible V is value. Is that the real data? Is that the important data? We need to find out what is the valuable data. And veracity, is it simply wrong? So again, that same earlier speaker mentioned that they found that a low BUN was important. They hadn't thought of that as a possibility, so nobody would have ever thought to have done a randomized controlled study on low BUN. But using big data, real-world analytics, that number came out. Now the obligation, if we follow the suggestions of Nate Silver in his book, Signal and the Noise, okay, that may just be random nonsense, but now it gives us something to look at, to say, is this really a valuable indicator? So we're working in big data because it's the only thing that gives us a real chance to gather the information we need to make personalized decisions. And in the area where I work, which is predictive analytics for patients with complex chronic disease, we use patient-reported and data acquired from the home to look for patterns that say this patient with CHF and COPD is going to get sick enough to need hospitalization in 4 or 5 days.
Awesome. Thanks, Marty. We're going to go ahead and move on with the panel now. Our first panelist is Eric.
Thank you. I want everybody to stop for a second. The technology that you've been hearing has been absolutely amazing. But I think there's a parallel track that needs to be integrated into everything that we're doing in technology. And here's the reason why. There are 16 million children in the United States that suffer from food insecurity, as an example. And unless you look at the social determinants of health along with the technology, you're never really going to appreciate the kind of cure and success that you want. If you don't look at hunger, if you don't look at environment, if you don't look at poverty, racism, and address those issues, then I can tell you that no matter what kind of cancer treatment you come up with, you're not going to be successful. I took a tour of the UCI Cancer Center, and I asked the director, do your patients suffer from food insecurity where they don't know where their next meal is going to come from? The answer was yes. They are now incorporating into their intake the 2 questions on food insecurity. We developed a campaign called Waste Not OC. We're ending hunger in Orange County. We're increasing the donations of restaurants and grocery stores. We're identifying people in need. And we have a Google map on our website of all the food pantries. You put in your zip code, and it says this is where you can get the food. And as a pediatrician for 40 years, I've never, ever asked any of my families if they've suffered from food insecurity. Chalk Hospital, Children's Hospital of Orange County, on every admission, they are now asking those 2 questions, and there's been over 30,000 families screened. So as you're hearing this technology, the harder thing to fix are the social determinants of health.
Very good. I'll open up questions to the panel to ask. I've got one in the meantime. So you guys were the ones that showed that the #1 cause of readmissions was, the predictor of that was the low BUN, right? Was that wasn't you? Okay. That was Bill. Well, but that's, okay, so that goes along with it though. I mean, that's just right in line with it.
You know, when I heard the presentation on diabetes, he said the diet, looking at carbohydrates and things like that, if you're dealing with 16 million children nationally, you better focus as well on the fact that not everybody has a appropriate diet and not everybody's being fed.
I agree with you entirely about the social determinants of health, and I think our ability to capture the data and translate that into projecting what the quality of life is going to be for our patients after the treatment they receive is something that's hard to capture. There will be increasing efforts to do that. But that has to be somehow, I think, one of the final outcomes of the data that we're producing on a clinical basis, because that's the end game for so many of our families and their patients.
And we fall short. You heard the entire conversation, and when there was a presentation this morning on population health, I mean, if you overlay the socioeconomic status of the county that you're dealing with, and you throw on all the other indicators, family size, housing, I mean, you'll find that there are going to be areas of asthma, for example, that you can give them the best treatment in the world and the predictors and things like that, but if you don't change the environment or the living situation that they're in, you're not going to be successful. So I agree with you.
In that same context, I'm thinking about the adequate diet, not getting access to food or having too much access to the wrong kind of food. I live in New York, and when Mike Bloomberg was mayor, he tried to implement this tax on these huge, high sugar drinks to reduce the utilization, and then the beverage companies came back claiming it was an infringement of freedom. How do we deal with these adverse incentives to actually keep the diets unsatisfactory?
So as the public health officer for the county, I believe that through education, you're going to be able to accomplish the things that you need. And this adverse incentive is being used as a part of a campaign for education. And that's the major reason for the way it is. So in our county, for example, it's very conservative. It's going to be very hard to pass those kinds of laws, but there's no reason for us not to work with the families and the patients that we take care of to incentivize them on what's important and what isn't.
Very good. All right. Next, Peter.
Thank you. Good afternoon, everybody. I wanted to follow on from Suresh a little bit of talking about early warning systems within critical care. I've spent the last 25, nearly 30 years now in pediatric critical care. That's not mine, but I'll keep talking anyway. And Marty, I'd add one more V to it, and it relates to critical care, and that's vexing. There is so much information that we have to absorb and integrate, and people do it in various ways. Some people don't do it at all, and with various effect as well. And I've really had to rethink what my job description is over the years, and it's really that as a forecaster and as a risk manager.
Go to the next slide, please. Did y'all take his out?
Keep going.
Keep going. So part of the value and the need for using, I'll keep talking. So one of the most important things in critical care and using data wisely is being able to use it at the point of care. Too often in the past, data has been collected, stored, sent out. Smart people have done things with it, and at some period of time it's come back to us, potentially into a clinical role. That's just far too late in the whole process for us to be making rapid decisions. So we needed a real-time data analytics platform that would enable us to do that. The first thing we did was to say, well, let's first of all make sure that we can capture that data, store it, and then structure it in a way that it was very accessible. And I don't mean in hours, but within 2 minutes through data compression and through distributive computing, so that you can actually get to the data very quickly and at the point of care at the bedside. Once we started to do that, we were then able to start looking at it and visualize it in a way that was meaningful to people at the bedside. And the visualization component of this is often not appreciated. The way we are very visual, obviously, in the way in which we think and work with our patients. So having a platform that enabled us to integrate with the data, drag and drop, zoom in, zoom out seamlessly was very critical, and to overlay variables so you could see the relationships. That was a very important part of the T3 program that I started in Boston in 2010, and it's in Toronto. It's now in 4 or 5 other hospitals, and the goal of all of that is to eventually have this integrated platform of a huge amount of continuous physiologic data. Because what we want to do is be able to describe the phenome. What's the physiologic state that our patients are in at any point in time? Yes, predicting an event is very important, but at the same time, there's sort of this gray box methodology where we really need to understand what's the underlying physiologic event that's evolving here, because that's what's going to predict the care that we provide. So our focus has been on first getting a visualization platform, and that platform is critical because we have a stability index, which is basically a Dow index, and we plug in various variables. We then can track that patient specifically based on their diagnosis and their procedure and their expected course in the ICU. So we have that platform that enables us to look at the trajectory of the patient. But we also have this platform that enables us to do a deeper evaluation in terms of looking at the underlying physiologic states, such as inadequate oxygen delivery or their state of ventilation. All of those can then be part of a machine learning algorithm that we can then also display and see real time at the bedside. The third component of this, which comes to the risk management piece, is that you then need to have a platform that incorporates not only that information, but all the other sources that are available to you, whether it be from the EMR or other areas, because then you can start to reduce your variability in practice. Then you can start to actually reduce your resources, improve quality, reduce costs, and perhaps most important, change physician and clinician behavior at the bedside. Thank you.
All
The
right.
slide didn't come up,
Very good.
but that was a summary.
I'm sorry
the
about the
problem with
slide. That caught me off guard as much as it did you. In the interest of time, I'm going to go ahead and move to the next one, but I've got a big question coming up for you at the end, so I just want you to stew on that for a little bit. All right. Next, we've got Kevin, and if we could go back to the slide that's got the blue and the black and the graph that surprised us all.
The problem with the slides reminds me of a motto that our CEO has, is that AI is easy, AV is tough.
That is true. All right, are you guys able to control the slides or not? There we go, that's the one.
So good afternoon. And when I was thinking about putting my slide together and just knowing that there are a bunch of intensivists up here, and so much of what we think about big data and analytics and machine learning, and just that, you know, the ability to be able to predict what's happening with our patients, and so that's certainly what I expected some of this to be about. But then one of the things that always troubles me about, you know, advancing technology, and so everybody thinks, you know, about this exponential curve and where is that yellow line headed. And so far as big data and analytics, and it's so much of computing power, and that's obviously just continues to accelerate. And at some point, we're going to get to quantum computing, and it's just going to change everything all over again. So if the first little red arrow is today, and this technology and software and everything is accelerating so rapidly, where is pediatric healthcare? Where is pediatric data analytics? Where is that going to go? And can we keep up? And I think that's, you know, one of the things that's so important about getting, you know, a meeting like this and having Anthony push all of us to try to think about that. But as our institution goes forward and everybody works, you know, to develop their own algorithms and what's going to be the best one, and how do we get the best care for our patients, and how do we keep up with technology, I think it's going to be an important part of the future of this field.
Very good. Shall we move on or do questions? Let's go ahead and move on, and I think we saved all the questions for the end.
I think that is an incredible observation and a crucial observation. I mean, we know that there are two different cultures between technology and medicine, and this conference and others are trying to pull them together, but that growing gap will certainly continue to grow. What are the solutions? I mean, we are having a festival of the great technology, but when we hear problems with malnutrition amongst us, where do we address that gap? You've been thinking about this for a while. Nobody has a gap adjustment, right?
All right, so in the context of that, I actually will admit that I cheated and read their slides a little bit before we came on stage, and I wanted to kind of combine Peter's and Randall's point on their slides as they're talking about a very big need, which is in the ICU, and we heard this earlier today, in the ICU, at the end of the day, all of the data that's generated is something that we have to interpret. We have to go gather it and then analyze it. And both of their visions are to get this data aggregated and pre-computed in a space so that they present us with a, you know, an easy to understand display. And the question then is, as time goes on and more and more and more of these data streams come on, and then you add on home data streams on top of that, where do you see the accountability going? Because at some point you start making assessments that somebody needs something or needs to do something based on the data stream when they would have been ignorant of it. And every time you do something, there's a risk of a complication happening. So can y'all talk a little bit about kind of the unintended consequences of having more access to data?
Well, it's interesting that you raise the question of the temptation to treat. As intensivists, we really want to do something for our patients. And I guess my learning in the last 40 years of doing this is I try and put a leash on the fellows and say, we have tremendously powerful tools. And when you unleash them on a patient, there will be consequences you haven't anticipated. So that's been with us a long time. I guess I have never thought of more data as making that worse. I'm actually hungry for more data to be able to predict when it's safe to unleash those powerful tools against our patients, or at least in our patients' behalf. So I'm afraid my answer is going to turn yours around, and we are friends. I think the solution is having that data and predictive analytics and really allowing the data to teach us about how critical illness happens to children instead of my biases and preconceptions, et cetera.
Peter, do you want to comment?
I have two comments related to that. First is I think that you've got to be cautious about how you utilize that data, capture everything, but then putting it into a haystack and trying to find a needle within that can be problematic. And I think that's where the context comes into it. So we can't divorce ourselves from that, and the clinician scientists, clinician data experts, computer experts have to coexist. I think medicine and engineering is the relationship now that will take us to the future, and they should be embedded within our intensive care units and help us in that regard. So I think you've got to be cautious as to capture everything, but there needs to be some filtering here. I think the other way to think about it is that we really should be able to work in probabilities. What's the likelihood of an evolving clinical state? It's 90% that this data is indicating this is what's evolving. And you should be able to then be guided. It's not a dichotomous 0 or 1, but it's a graduation. And I think we should be able to use our data analytics to help us in that, to give us that probability.
Yeah, I think that's the purpose of having the human in the socio-technical system working alongside that and having that expertise, of partnering in the development of that before the data just shows up.
Which is a great segue into our final panelist.
Oh, thank you. So if you bring up my slide, you skipped him?
I thought you talked. I was answering the question. Oh, sorry, yes, okay.
Dr. Wetzel, please share with us your thoughts. Do you have anything you'd like to say? Anything at all?
I do actually. I was trying to resist going into a conversation of how much human intelligence we put into it. I think the greatest threat to artificial intelligence is human intelligence, or really rather the lack thereof. But that's just to be argumentative. Can I see the baby? We've seen the baby a few dozen times here. And I'd like to thank everyone for staying this late. And know that you're probably tired. I'm also an anesthesiologist, so it is my job to put you to sleep. So first it needs to be audience participation here, so first I'm going to ask you a question. In what year did, let's say, medicine save more lives than it cost? I.e., when did healthcare save more people than it actually bumped off? And I do have a year, a specific year, but I'll shout out some numbers, 2000 BC, 1452, 40 years before Columbus left Spain. Good. 1452, okay, now let's have an auction. Which way do we go from there, before or after? After, okay. 1963. Ooh, 1963, that's good, that's good. 1920. Okay, almost directly in the middle of that, 1949. This is actually a demonstrable fact, and it didn't really have anything to do with the doctor as well. It was a doctor. It had to do with antibiotics. which took a long time to come on board, just like hand washing took a long time to come on board. The next significant thing happened was that Peter Solowitz realized that machine learning might be applied to healthcare in around, I think he said 1975, when I graduated. Is he gone? Oh, you're over there. When I graduated from medical school, and for the next 20 years, I did prospective randomized clinical trials and some basic science bench research that was all hypothesis-driven and funded by the NIH. And then I did an MBA and found out there was computers and information science that was used everywhere but besides in healthcare. And it occurred to me that the patient is data. And I thought I was very clever to think of saying that, but it really annoyed people to refer to patients as data, but you've heard nobody objected to hearing that same thing today. Now, who was the first person to say that? I thought it was me. And this ties up to, why did people keep doctors around for 4,000 years of human history when they killed more people than they helped? What was their value? Did healthcare and physicians provide something to society so that every human society we know had shamans, witch doctors, priests, curative people? What did they bring, since they didn't bring treatment, and in fact, they might kill you? I think it's an important question because what we do needs to also think about those things. And in fact, Hippocrates was the first person to say, look at your patient, learn from the observations. The Greek word for observations is the same as the Latin word datum. So look at your patients, learn from the patient's data. The patient is data. You should learn from that experience. We're still learning from that, except now we have a much better ability to look at that, and we can now actually capture all of this stuff. So in 1997, having realized the patient is data, several pediatric intensivists got together and formed something called the Virtual Pediatric ICU, whose purpose was to capture and analyze that data. The mission was, in 1997, to create a common information space. I think I heard that referred to today as an internet of hospitals, but I think we think of it as an internet of ICUs. Ours wasn't to predict. I think Peter did a good job of saying there are two really big main themes here. One is to predict when a catastrophe is about to happen to your patient, pediatric early warning systems, Rothman indices, all those things. And another one is to try and understand what's happening to your patient in the context of what's happened to previous patients. That's what I've sort of mostly been involved in. This has evolved into a network of 160 hospitals that send information about every single pediatric ICU admission. We now have over 1 million pediatric ICU admission data, which has resulted in hundreds of papers being published. But that's not the fun part. The fun part is now finally having enough data and enough people politically connected that we can actually start collecting much more granular data and address with machine learning. And some of the things that we have approached to do that is predictive algorithms so that we can say, this is what should happen in your ICU, this is when your patient should go home, this is the percentage of patients that should be on a ventilator, this is how many patients should survive in your ICU. And the other thing that drove me in this area was every ICU I went to for years was the best ICU in the world. And I'd been to 50 of the best, no, not of the best, 50 the best ICUs in the world, and there was no standard to measure this. So we needed a model that said how an ICU would perform to collect that data, analyze it, develop a model. Mostly that was multiple linear regression analysis and logistic regression analysis. Now we're using Bayes networks and moving into recurrent neural network analysis of some of this data to try and say, this is what really should be going on in your ICU based on what's gone on in all those other ICUs. I want to remember, as Paul said, that he kept me up very late last night. He blamed me for keeping him up. You can imagine who I blame. And so I'm a little confused. I have 4 observations I want to make quickly. And of course, I can't remember them. I'm watching. I have 1 minute.
You're a minute over.
Oh. I'll make the observations when you ask me a question. How's that? Now, data quality is important. That 160 ICUs is a multi-million-dollar going concern. The people who send data spend $20 to $25 million a year to send that data. They don't pay that. That's what it costs them to collect it, put it in order. That's a phenomenal drain. We need to find a better way to do that. Politics is slower than technology. I think that really was what that graph was. The technologic solutions weren't here in 1997, but they have far surpassed what we're doing with that technology now. I heard Peter Van Manen about 5 years ago, the chief science officer for McLaren Racing. Formula One racing cars are incredibly well monitored. They took their software and their predictive analytics and they stuck it into the health system in Birmingham Children's Hospital, and with very little modification were able to predict where disasters and where catastrophes and when physiologic states changed for the worse. That's been around for years. We're not applying it, and we have multiple different approaches to that same issue. I mentioned that we need to continue to build an internet of hospitals where all this data is commonly held. It is a valuable resource for all of us to be analyzing. And finally, this gets back to the question how much humans can be involved in managing the data. I think it's really important to be sure that we don't introduce, medicine knows a lot of things, but we don't know the certainty with which we know it. Ambiguity is huge, and we have treated patients with steroids we shouldn't have, ventilators we shouldn't have. I could go on a long time, and leeches longer than any of those, because we knew that was the right thing to do. We need to really dispassionately not assume that we know anything about the data, but to really let the data speak for itself and understand how critical illness happens to kids.
Amen. All right, so now our final panelist of the day, Eric Williams.
No worries. I'll just be quick like I usually am. And I know I was told to sit, but I can't, and I apologize for that. So there's so much great energy here. There's so many wonderful things people are doing, and you're all going to go back to your institutions, and there's going to be an individual or individuals who are going to be a barrier or a roadblock to you moving forward with your innovation because they're thinking like this, right? And so, you know, I'm going to make this interactive, and so let's work it out. So we work in a well-designed system, true or false? Very false, right? So yeah, so that's not true. And Paul referred to it earlier as it's poorly designed, and I would say it's undesigned, right? I mean, new things come along, and we try to do the right thing. So well-intentioned people trying to do what's right for patients, and they're in the moment with that. And so take alarm management. So we have alarms because someone says, I'd feel safer if we had one more buzzer in the room, right? And so it evolves over time, and then new monitors come out, more time passes, monitors with more features on them come out, and then the space grows, and we have a 36-bed step-down unit for complex kids, and this is what happens. So 36 kids, complex in nature, and all those alarms go to a central station. So what now happens 24/7, 365, right? So if you want to make an impression on an executive, take this is interrupting, right? Take this to your next meeting and leave that on during the meeting. So the recognition that alarm fatigue is bad, right? It's a bad thing. So, look, and I can't even stop it. It's appropriate. So the next piece about we understand what is actually going on. True or false? This is actually super false, right? Because we know very little about what is actually going on, and we imagine what's happening in there, and we make assumptions about that, and it's very, very untrue. I believe it was Thomas from Kenya mentioned, he felt that the people in his country were always adapting in the moment to do the right thing. And I would say we're constantly doing that too here, but we never measure it, right? People are constantly adapting to the work and the needs at hand to do the right thing for patients, and we usually get a good outcome out of that. But on rare occasions, we don't. And then so we have this big, long horizon of outcomes, and the majority of them are good, and we don't know why. But on a rare occasion, something bad happens, tragic. We do a root cause, and we find two things. There was bad communication, and someone didn't follow policy. So we're good fixers, so what do? We educate to the policy, and we counsel that person, right? We, do a better job next time. And the policy said, don't do stupid things. It says it right here, and it's on the internet, right? And so we struggle with that, but yet we go down that pathway. So we partnered with Medical Informatics Corporation, going back to an alarm analogy, to find out, well, what is actually going on with alarms? And when you actually pull the alarms from the monitors and look at them and create a topology of alarms, you learn that Some patients are alarming for 4 hours out of a 12-hour shift. And you realize that's not a patient that was deteriorating. So that's when you go into the room, that's a patient doing cartwheels in the room, and it's a lot of noise going on, but we have a policy in place to do that. So again, so what is really going on with that? And the poor parent who says, can we turn this off? No, that would make it unsafe. We wouldn't know when your child was dancing, in the bedroom there. And lastly, you could see this, do we always fix the correct problems? And the answer is no, right? Of course we don't, because we've set ourselves up for failure with this. So the goal is, what is actually going on? Think about the power you would harness if you could actually know what was going on and address those issues. So that's that resiliency piece. So how are people with everyday clinical work getting to success? We don't measure that, so that's the next piece that's out there. So when you go back to your institution and you're hurtling down that pathway of taking nanomedicine to do something related to antibiotics, ask yourself, are we all washing our hands? And secondly, if you're going down and you're accurately diagnosing cancer in a more specific way, how are you delivering that message back to the families? Because what is actually going on, that's what it is. And so I believe it was Wendy who started this off with that reference to the IHI's new aim that they're trying to push out of, if we radically redesign healthcare, how will we break the rules? What are the rules? And it turns out next week is Amnesty Week, where they're asking hospitals to ask the people on the front lines to determine what are the rules you're breaking or should break. So break the rules next week. And remember, big data starts with any data at all. Thanks.
Yeah, one of the concerns I have about this focus on data and devices and systems is being controlled by it, instead of looking at it as something to help us make better decisions, something that focuses our decisions. And one of my colleagues said, that came up, remember to look at the patient, stupid. I can recall times in the emergency departments trying to speak to the surgery resident about a patient with belly pain, and he cut me off when I started to describe the abdominal exam, said, what does the CT show? Doesn't even want to look at the patient. And one time when I was a chief resident, and part of my assignment was to be the ICU resident at a small community hospital that had a small residency, and I responded to code 3 in the emergency department. And the senior resident was supervising 2 interns in this resuscitation, and one resident was sitting astride the patient's belly, pressing on his chest. Another intern was trying to start an IV in the guy's right arm, and the patient shouting at the top of his lungs, the next son of a bitch who pushes on me is going to get the crap beat out of him. Nobody stopped and looked at the patient. So we need to be careful. I mean, there are some people who argue that computers are going to take over for physicians. I think that's unlikely, although Vinod Khosla and I have debated that a few times. I think Warner Slack's response to that is the best. Any physician who could be replaced by a computer should be. But we need to look at it as augmentation of our decision-making ability, not dominance of it.
All right, thank you, everyone. We appreciate it.